To share with you some work that we did in understanding the impact of different priorities within tuberculosis control and prevention within our province of Saskatchewan. I'm going to be illustrating today the use of techniques for carrying out a model using what's called system dynamics and how it was used to build in this case, a quite simple and fairly quickly constructed model together with our tuberculosis control program for our province. I'm also hoping that this talk will highlight two additional items of note. Number one, the fact that the sorts of tools that we use here, while they're often most obvious in terms of some of the formalisms involved is what stands out for different approaches to modeling. One of the most important things about system dynamics as an approach is its emphasis not only in building a working simulation model, so you can ask these sort of what-if questions like David has talked about, but also the emphasis it places on changing people's mental models, changing how people think about a problem, and particularly how stakeholders involved in the problem conceptualize their role within that system and understand, reconceptualize the problem as a result of the modeling process. So you'll see that. I also hope you'll get a glimpse of how one particular system science technique, namely system dynamics, can fit in a broader milieu which incorporates a research program making use of multiple system science techniques together with traditional techniques. So within today's talk, I'm going to begin with a bit of background on tuberculosis for those not familiar with it. Tuberculosis is a contagious airborne disease spread by the Mycobacterium tuberculosis, and it's one of the most ancient infections known within the world. It's a highly prevalent infection. If you look worldwide, it's estimated that approximately 1/3 of the world's population is infected by Mycobacterium tuberculosis. The disease continues to carry out its a dreadful scourge worldwide, with particular rises in recent years within death rates associated with late-stage HIV co-infection. There's a number of risk factors for it, and some of these risk factors are notable in the sense that they've been explored with additional system science techniques. So, for example, Kristen Hassmiller-Litch, a student of Dr. Mendez here, and others have worked on looking at the interaction between smoking and TB through a system science lens, showing the power of the system science lens for illuminating some of the indirect costs associated with smoking that go beyond traditional accounting. And second of all, some work of ours outside the scope of this presentation has particularly looked at the impact of age and ethnicity within the Northern Canadian context. Prevention and control measures for TB focus on the gamut from vaccination early in life, most traditionally with BCG vaccination, chemoprophylaxis for individuals who have been infected to prevent them from developing active TB disease, directly overseen treatment regimens to lower the risk of development of drug-resistant TB, and a variety of active measures, most notably contact tracing mechanisms, whereby we go out and find individuals who are at greatest risk and bring them in for either direct treatment or chemoprophylaxis. What's notable about this disease, for the purposes of this talk, is that it's a two-stage process with a very, very long latent and incubation phase. So individuals may be infected, sometimes early in life. However, 90% of those individuals never go on to develop active TB disease. They stay in a state called latent TB infection, and approximately 10% of those individuals will go on and develop active TB over their lifetime. About half of those within the first 2 years following infection through a process known as primary progression, and about half later in life, perhaps following the development of co-infections with HIV, undergoing organ transplant and therefore use of immunosuppressants, or other depredations in life that may lower the immune strength. It's notable that active TB disease can either be infectious or non-infectious, and contact tracing programs are particularly notable for putting a premium on trying to detect cases while they're still non-infectious and bring them in for prophylactic treatment so that they can be stopped before they develop full infectiousness. A little bit about the geographic context. This work is taking place in our province, Saskatchewan province, a Midwestern Canadian province of approximately 1 million people. Saskatchewan is notable for a number of firsts and really played a leading role within the fight against what was known as white plague during the 1900s, with the first introduction worldwide of free treatment in 1929, 1928, which brought people out of their homes and out to get treated, with the introduction of BCG vaccination among healthcare workers, again a world first, and with mass screening also began in the 1930s. A really massive, large-scale, province-wide effort ended up yielding great dividends in the 50s and 60s with declining rates of TB, but the disease has remained stubbornly persistent within our population. What's more sobering and particularly relevant for this crowd is the fact that we see tremendous disparities associated with the prevalence of TB in different groups. Most notably, we see, from a geographic perspective, a large preponderance and real disparity in terms of the incidence rates in the north and south of our province. Something which mirrors the fact that if you look at stratified by ethnicity, the rates are much, much higher among our Aboriginal population, which include, in this case, registered Indians, but more broadly include the Métis and some other groups as well. And this is in contrast to the other Saskatchewan population, where the rates are more typical for industrialized contexts. To confront these challenges, we've mounted over the past 5 or so years, with support from the Saskatchewan Health Research Foundation, National Science and Engineering Research Council, and other agencies, we've mounted a multi-pronged approach to addressing the scourge of TB within our province. This has included a variety of, in fact, all 3 major system science techniques: social network analysis, system dynamics models, and agent-based models. We've also done a variety of primary data collection, most recently involving smartphone-based contact detection systems, and also looking at physical measures to measure risks associated with tobacco exposure through use of hair samples and measuring both active and passive smoke exposure through assays designed to detect nicotine levels in hair. We've leveraged a variety of dynamic modeling techniques and some cognate approaches, such as decision analysis, to really bring a full-blown attempt fitting the type of technique to the particular problem to try to understand different aspects of tuberculosis and particularly policy-relevant questions. It's notable that there's 2 routes to TB diagnosis that are used within our province. One is through the use of active tracing and screening, going out there and finding people to bring them who may be at risk. And secondly, a passive diagnosis, which involves typically presentation to a doctor for care. And what's notable here is the quicker we can get time to a diagnosis, the quicker we can bring someone in, detect they're at risk and bring them in, the less chance they'll have of developing to the point where they may develop very active TB symptoms that threaten their life, and worse yet, threaten the lives of others by spreading the pathogen. So within our province, we make very heavy use of contact tracing investigation. This has been going on for the better part of a century. We go and we try to find individuals at risk by tracing the recent contacts of infectious TB cases, and in some other cases, such as primary TB cases, these are primarily in children, and we try to find individuals who have been recently infected, people who have active TB, and people most notably who have infectious TB. And traditional contact tracing here focuses on individuals who have large amounts of exposure with the case and tries to bring them in with a particular priority, and some individuals within households. And through this process of contact tracing, the administrative data collected, we've accumulated quite an understanding of the contact networks involved in TB transmission within our province and their geographical routes. Now, the background for this work in terms of topics that we're trying to investigate within the TB context was strongly motivated by ongoing meetings with our TB control authorities. And the head of it brought to us questions, for example, regarding the devotion of resources to contact tracing. Where would those resources be best invested? For example, the province was falling far short of its goals in terms of the speediness of contact tracing. We were falling short of goals of bringing in within a month's time approximately 95% of all contacts. And there was a very real question: was this costing us greatly in terms of the spread of TB? Other questions concerned how broadly should we bring people in for contact tracing? Are we bringing enough people in? And should we bring, what would be the added benefit of bringing in many fewer questions? Other questions had to do with who do we actually follow up to perform a contact trace. These questions were investigated further but fall outside the scope of this presentation. So we created this exploratory model within the scope of about 3 months' time to investigate these issues of scope and speediness of contact tracing as part of an element of a larger research program that I noted earlier. So the model objective was to understand dynamics of TB transmission and contact tracing, particularly within our north, and to try to evaluate the trade-offs associated with finding people faster, finding people in a more inclusive way. So the basic structure of the model that we used for this investigation is illustrated here on the screen. System dynamics is a very emphasizes use of easily understood graphical representations, in large part because those facilitate understanding by stakeholders. And we would often meet with our TB control personnel showing these sort of diagrams so that we could discuss with them the scope of the model, how we characterize things, get feedback from them, and elicit questions from those individuals within the TB control program. In this case, the model divided up the population into a set of different categories. Those categories were distinguished by natural history of infection, broadly shown top to bottom, but also distinguishing individuals by whether their situation was known to the healthcare system, that is, whether they were investigated or otherwise. Finally, in addition to classifying the population to a set of categories, we had a further stock that was associated with a set of individuals who are queued up for contact tracing, a set of individuals that we were going to have to work through to trace their status within the population because they have been reported as a contact by another individual. And these individuals who are named, the number of individuals who are named would grow as new cases presented that needed to be traced. And they would be drained, thinking again of the bathtub analogy nicely highlighted by Dr. Mendez, they'd be drained as we work through each successive individual in a manner that was based on familiarity with how the TB control program worked. As David had noted earlier, these models typically require, while they depict sort of an overall situation, to be adapted to a particular context. They require data to be placed into this model, and in this case, we've benefited greatly from our work with the TB control program and extensive data they had collected on the communities at issue. And we went through a process known as calibration, where the model, for certain parameters that are less well known, we attempt to adjust certain those parameters to best match historic data. And fortunately, we had a variety of data related to TB in Saskatchewan and some in these communities to which we could use for calibration. So I'd like to spend a little bit of time here talking about some of the findings from this model and how it stimulated further work. So the first thing we looked at, again, these were issues that were identified through ongoing contact with our TB control program, had to do with the scope of contact tracing. How broadly do we attempt to find people? Does contact tracing matter? And if so, how broadly should we be doing it? So in answer to these questions, using the model that we have created, we examined the effect of different scenarios where different levels of current, compared to current contact tracing, were undertaken. So if we consider 100% sort of the level that typically involves bringing in about 40 contacts per case, what if there were, for example, no contact tracing done at all? How would that vary things? And the answer is, well, it would almost double the prevalence rate associated with active TB. Contact tracing, ladies and gentlemen, although it had been criticized at times for being very resource intensive, for tying up a lot of nurses' times, really was making quite a lot of difference in terms of lowering the burden of TB, particularly in some of our most vulnerable populations. However, what we found is a striking differences in the gains associated with undergoing contact tracing at different amounts. For example, if we were to contact trace at the 50% level, we could, through that first 50% level of today's contact tracing, we could greatly lower the burden from the blue to the green line associated with the prevalence of active TB. But going the extra mile and bringing in that second 50% of people compared to today's levels of contact tracing would only reduce the levels of TB within the population by a quite small amount, often for quite a lot of extra burden, at least doubling the burden, and actually probably going beyond this, because this gets into some of the trickier cases. So we found that contact tracing was making a difference. It was helping drain the swamp, so to speak. But it was doing so in a way that was most efficient for even just starting out with contact tracing, and it exhibited diminishing returns. It exhibited returns which were progressively more and more modest as one expanded it, for progressively, on a per-case basis, more and more work. The second set of findings related to the speed of contact tracing. There was a lot of worry that we were missing cases, that because we were falling almost 3 times short of the formal goals for bringing people in, that we may be shooting ourselves in the foot by allowing TB out in the population to breed, to spread, and bringing people in only after the cat was out of the bag, so to speak. So we looked once again at the prevalence of active TB based on differential speeds of contact tracing. And what we found surprised us greatly. And 2 notable features are present here, and I'll highlight a third in just a second. Number 1, if we look at the baseline, the green line here, if we were examining effects of going slower than the baseline, we would see adverse effects. But they were exhibited in a much less pronounced way than we expected. Even a huge difference of something like going 10 times slower in contact tracing could still yield a large fraction of its original benefits. 20 times slower was still quite a large fraction. But if we started to increase the speed of contact tracing, even going through heroic efforts to bring people in remarkably little time, it yielded very, very little benefit beyond today's levels. Putting in a massive effort to bring people in at 1/10 the speed at which we did it now, bring them in 10 times as quickly, which would require a massive coordination and full court press, would yield virtually no benefit in terms of the prevalence of active infection. And the insight here, ladies and gentlemen, is that there's natural time constants associated with TB spread, how quickly we can test someone and get a positive result. There's natural time constants associated with how quickly people present for care as well. In a model which takes into account these time constants, takes into account the impact of actually going faster or going more slowly, can clue us into the fact that a big investment in this area, like was being considered, really wouldn't pay off. It would be much more effective to put those efforts, for example, into the scope of contact tracing, or, as this model helps show, to help prioritize contact tracing more effectively. Another curious factor that this model helped demonstrate here was visible in many runs that we ran, and it was a counterintuitive phenomenon. In some cases, we found if we improved the speed of contact tracing, some of the measures that we would use to traditionally evaluate the effectiveness of programs would suggest adverse outcomes. For example, initially, if we had faster contact tracing, the fraction of all cases that we would find through active methods, such here contact tracing, among all cases, would initially rise quite strongly, but then would actually decline below its baseline levels. We would actually find fewer people in this counterfactual situation where we were performing it much faster, for example. And we were unclear why that is. How can it be that doing contact tracing faster decreases the fraction of people that are found from it? And you could see this effect most pronounced, actually, if we compare speeding it up from a very slow rate to a less slow rate. And the answer here was that in fact, performing contact tracing, performing faster speed of contact tracing, does in fact identify more people at risk. But if you do it enough, what you find is that you're draining the swamp enough that there's not too many of those people out there that you can find associated with this contact trace. Those people which you're going to be able to find out there that are in fact do have TB control will probably be people reactivating after long periods of latency, who you're not going to find through your contact trace. You're going to find those typically through passive mechanisms. They're going to develop a persistent cough, they're going to see their doctor, or through screening, other screening type programs. So in short, we identified a situation where a traditional measure of effectiveness could be problematic. Okay, and broadly speaking, this helped the realization within the contact tracing, within the TB control program, that contact tracing is self-limiting. And voices which are out there which question the effectiveness of contact tracing say, why are you putting all these efforts into this mechanism which is not very cost effective, where you put a lot of money in for each case found, maybe we should back off from that. It turns out that that's a flawed argument. It is true that contact tracing, when done successfully, almost by definition makes itself inefficient. It makes itself seem cost ineffective because it's drained the swamp so effectively. Those people who say, well, that's an excuse to back off now, we've done our job, let's reduce it, it will explode in your face if you really back off. You're asking for trouble if you use narrow cost effectiveness arguments to say that we should cancel contact tracing mechanisms. The fact that it is getting to the point where it doesn't seem so cost effective is a sign of how successful it is. And you need to have a more proactive, a more dynamic cost effectiveness proposal, such as has been advanced by Kim Thompson and Ginter Tebbins, for example, in the polio area, to really see in big picture how cost effective are these programs. The second big emphasis that came out is the impact of prioritizing contact tracing and its importance. Just as a postscript here, because I've got to finish up, I should note that this worked, and the fact that we were able to highlight prioritization is so important allowed the construction of an agent-based model, which allowed us to, in detail, which was much more of a large undertaking, but allowed us to examine with great detail the trade-offs between different prioritization mechanisms, including some that take into account, for example, someone's network position, their past history of presentation with TB, and other factors. So here, we helped prioritize our research efforts using the simpler model to put those efforts into a place where they would yield the greatest benefit. So in conclusion here, despite the inherently network-based nature of contact tracing, we found that system dynamics model could give great insight. And in fact, it yielded results which were reinforced by, re-emphasized by, and deepened by subsequent modeling, in that case with an agent-based model. Results from the system dynamics helped highlight broad trade-offs between speed and breadth of contact tracing. and helped inform discussions by the TB control program as to where to invest resources. And it highlighted against prematurely writing off contact tracing as not cost effective, pushing back against overly narrow application of those sort of criteria. It did help influence this mental model people had about how to judge contact tracing, and the mental model that people had in mind about the possible benefits associated with speed of contact tracing. This SD model remains of great value to our program for a variety of more sophisticated analyses that we can't conduct with the agent-based model, and that involve use of Markov chain Monte Carlo techniques and other more sophisticated techniques associated with dynamic filtering. So I'd like to provide my sincere acknowledgments to those who have helped make it possible for me to come, be privileged to talk in this way, to the broader team, including several representatives from TB Control and for our funding. Thanks very much.